focusing on stenosing tenosynovitis of the wrist and hand. These are very common conditions that, despite being benign, often result in significant functional impairment. Fortunately, treatments are usually straightforward, and with proper management, symptom resolution is typically complete. When we talk about stenosing tenosynovitis, the most classic example is when the extensor pollicis brevis and the abductor pollicis longus tendons are affected within the first dorsal compartment. This is what we know as de Quervain's disease, first described in 1895 by the Swiss physician Fritz de Quervain. But the spectrum is much broader. For instance, peritendinitis can also involve the tendons proximal to the extensor retinaculum, producing pain, swelling, and crepitus. In some patients, small cysts may appear at the first dorsal compartment, and even tendon triggering may be observed. When we look at the flexor side, the long flexor tendons to the thumb and fingers are commonly affected. These cases present as trigger digits, in which patients describe a painful snapping sensation or even locking when trying to flex or extend the finger. Less commonly, the extensor pollicis longus tendon may be affected as it passes beneath the dorsal radial wrist. Pathophysiologically, the tendinosynovitis process can result either from abnormal collagen disease or from recurrent mild trauma. Think about repetitive microtrauma from occupations like carpentry or constant typing. Interestingly, some cases develop spontaneously with no clear cause. What happens is that at a critical point of tendon excursion, the tendon sheath acts like a pulley, and when fibrosis forms, friction is maximal. This friction is what generates pain, inflammation, and triggering phenomena. From a clinical standpoint, patients typically present with localized pain and swelling, sometimes accompanied by mechanical triggering. The Finkelstein maneuver, in the case of de Quervain's, is a classic diagnostic clue, but we must also remember to differentiate from other causes, such as arthritis, gout, or infection. Regarding management, most cases respond favorably to non-operative treatment. This includes rest, anti-inflammatory medications, splinting, and corticosteroid injections. In fact, injections can provide excellent relief, although patients should be warned that pain may transiently increase during the first 24 hours as the anesthetic effect wears off. It is also important to remind patients with diabetes that they may have higher risk of elevated blood sugar levels after corticosteroid injections. Surgery is reserved for resistant cases. It is typically avoided in brittle bone disease, poor healing potential, or systemic contraindications. Finally, clinicians must be careful with differential diagnosis. For example, middle finger osteoarthritis may mimic a trigger finger, while extensor tendon subluxation may be mistaken for simple snapping. Similarly, swelling of the dorsal metacarpophalangeal joint may look like stenosing tenosynovitis, but actually represents arthritis. In all these cases, careful examination, including checking for tendon stability over the metacarpophalangeal joint, is mandatory. In summary, stenosing tenosynovitis encompasses a range of conditions from de Quervain's disease to trigger finger, each with specific anatomic involvement but sharing a common theme: mechanical restriction of tendon motion within a fibroosseous tunnel, leading to pain, triggering, and disability.
Now let's move on to the surgical treatment of de Quervain's disease, a condition caused by stenosing tenosynovitis of the abductor pollicis longus and extensor pollicis brevis tendons within the first dorsal compartment. When conservative measures fail, surgery becomes necessary, and the goal is to decompress this compartment, releasing the tendons to restore smooth gliding and relieve pain. In Figure 76.1, we see the proper technique for injection. Regardless of whether the injection is performed from distal to proximal or in the opposite direction, care must be taken not to direct the needle past the radial styloid, as this would risk injury to the radial artery. This figure highlights a key exam point. Always be cautious with local anatomy when injecting near the wrist. Moving to Figure 76.2, we see the surgical field during an operation for de Quervain's disease. At least one aberrant tendon is often encountered. The abductor pollicis longus tendon may have multiple slips, sometimes inserting into the first metacarpal base, the trapezium, or even into the thenar fascia. These variations are clinically relevant because failure to recognize and release all compartments can result in persistent symptoms after surgery. In Figure 76.3, this anatomical variability is demonstrated. The abductor pollicis longus can insert proximally and medially into the trapezium or into the abductor pollicis brevis muscle. Remember for exams, the extensor pollicis brevis may be absent in about 5% of individuals, which can complicate diagnosis and treatment. The surgical technique itself is described in Technique Box 76.1. The operation is usually performed under local anesthesia with a tourniquet. The key steps are: first, make an incision over the first dorsal compartment, just proximal to the radial styloid. The incision may be transverse, oblique, or longitudinal. Each approach has advantages. The longitudinal incision, for example, reduces the risk of incomplete release but may lead to greater scar adherence. After careful dissection through the skin and subcutaneous tissue, the retinaculum of the first dorsal compartment is exposed. The surgeon must identify the extensor pollicis brevis and abductor pollicis longus tendons and assess whether there are separate subcompartments. If aberrant slips are present, they must also be released. Failure to address these anatomical variants is one of the most common causes of persistent postoperative pain. In Figure 76.4, the surgical sequence is illustrated step by step. In Panel A, we see the skin incision. In Panel B, the dorsal carpal ligament has been exposed. In Panel C, the first dorsal compartment is being opened on its ulnar side. And in Panel D, the wound has been closed with a small dressing. This stepwise photographic sequence is particularly valuable for understanding the procedure and is a likely topic for exam questions. Postoperative care is straightforward, as described in the red box. The small pressure dressing is typically removed after 48 hours. Thumb and hand motion is encouraged immediately, except for forceful wrist flexion, which could predispose to tendon subluxation in the early postoperative period. However, complications may occur. Failure to achieve full relief can result from several issues: incomplete release of aberrant tendon slips, excessive scarring, or incorrect diagnosis. One notable complication is volar tendon subluxation, where the tendons shift volarly after release. Figure 76.5 demonstrates a technique to prevent this. A U-shaped retinacular sling is created from the extensor retinaculum to stabilize the tendons, preventing volar displacement. In summary, surgery for de Quervain's disease is highly effective when performed correctly, but attention to anatomical variations, careful dissection, and prevention of complications are essential. For exams, remember the key points: anatomical variability of the abductor pollicis longus, the occasional absence of the extensor pollicis brevis, the importance of releasing all compartments, and the potential complication of volar tendon subluxation.
This section addresses trigger finger and trigger thumb, which are distinct clinical entities but share a common mechanism: stenosing tenosynovitis at the level of the flexor tendon sheath. In adults, this condition must be differentiated from congenital trigger thumb. The pathology arises because of localized thickening of the tendon sheath at the level of the annular pulley, most frequently the A1 pulley. As the flexor tendon glides through this narrowed space, it creates a palpable and sometimes audible triggering. Clinically, patients often describe inability to extend the digit smoothly, reporting painful catching or even locking. When associated with systemic diseases like diabetes mellitus or rheumatoid arthritis, multiple digits may be involved, particularly the long and ring fingers. A nodule or fusiform swelling can frequently be palpated at the level of the first annular pulley in the palm. This nodule corresponds to thickening of the tendon or sheath and is what produces the characteristic catching phenomenon. Pressure at this site accentuates the snapping sensation. Importantly, the examiner should be aware that other conditions may mimic or coexist with trigger finger, such as flexor tendon subluxation, intra-articular disorders like loose bodies, or arthritis of the interphalangeal joints. Therefore, a careful differential diagnosis is crucial, particularly in older patients. Treatment typically begins with non-operative management. This includes stretching, splinting, and combinations of heat and ice. Corticosteroid injection remains the cornerstone of conservative treatment. Clinical studies demonstrate a success rate of approximately 60% with a single injection. Some studies have shown that repeat injections may provide symptomatic relief for up to a year in nearly half of patients. However, in individuals with diabetes, steroid injections may transiently worsen glycemic control for several days, and in those with poorly controlled diabetes, surgical intervention is often preferred. When conservative measures fail, the treatment of choice is surgical release. According to large database studies, surgical release reliably solves the problem in up to 97% of patients, but persistence or recurrence can occur. An important teaching point for exams is that surgical release should ideally be performed under local anesthesia, often in a clinic or minor procedure setting, as this has been shown to be both safe and cost-effective. The figure on this page, figure 76.6, illustrates the infiltration of local anesthetic in preparation for trigger finger release. The injection is performed proximal to the site of the planned incision in the palm. This is a key procedural step to ensure analgesia and patient comfort. Moving to technique 76.2, the standard operative procedure begins with local anesthetic infiltration in the palm. An arm tourniquet may be used, but often an S-Marks wrap is sufficient. The incision is typically transverse, about 2 centimeters long, and is placed just distal to the palmar crease for middle, ring, and small finger releases, and just proximal for index finger releases. Some surgeons prefer oblique or longitudinal incisions depending on finger involvement. The critical principle is to avoid injury to the digital nerves, particularly the radial digital nerve of the thumb, which is especially vulnerable. Once the incision is made, the surgeon identifies and releases the A1 pulley, and this relieves the constriction and allows the flexor tendon to glide smoothly without catching. It is important to not extend the release proximally into the A2 pulley, as this may destabilize the flexor tendon. In summary, this page highlights the pathophysiology, clinical presentation, conservative management, and surgical release of trigger finger. For exam preparation, remember, the pathology is stenosing tenosynovitis at the A1 pulley. Corticosteroid injections provide 60% success after a single dose. Surgical release has about 97% success and should focus on releasing only the A1 pulley. Always be cautious about protecting the digital nerves, particularly the radial digital nerve in the thumb.
Let's continue our lecture by exploring two fascinating and clinically relevant conditions, Bowler's thumb and trigger finger, focusing particularly on the percutaneous release technique. Part 1. Bowler's thumb. Bowler's thumb is a rare but very characteristic neuropathy of the thumb. It results from repetitive compression of the ulnar digital nerve of the thumb, most commonly seen in bowlers who hold and throw the ball several times per week. Pathophysiology. The constant pressure leads to perineural fibrosis, which is a thickening and scarring process around the digital nerve. As illustrated in figure 76.9, the fibrosis most often involves the proper ulnar digital nerve of the thumb, but may also affect the proper radial digital nerve or even branches of the median nerve. Clinical presentation. Patients typically complain of tingling and hyperesthesia around the pulp of the thumb, a palpable lump that is tender and painful to touch. In advanced cases, atrophy of the distal skin due to chronic nerve compression. These patients may have significant impairment in daily life, especially if they continue bowling. Management. Early recognition is key. Simply resting from bowling and using a thumb splint can be enough in mild cases. In persistent or severe cases, surgical interventions may be required, such as neurolysis or even distal nerve transfer to bypass the fibrotic segment. Postoperative care. Postoperative recommendations are simple but effective. Cover the needle entry site or incision with a light, non-restrictive dressing. Encourage active hand and finger use with stretching exercises as tolerated. The goal is to promote early mobility while protecting the surgical site. Part 2. Percutaneous release of trigger finger. Now, moving on to trigger finger, also called stenosing tenosynovitis of the flexor tendons. In this condition, the A1 pulley becomes thickened and constricts the flexor tendon, leading to painful snapping or locking of the finger during motion. When conservative treatment with splints, anti-inflammatories, or corticosteroid injections fails, surgical release is indicated. One of the minimally invasive methods is percutaneous release, described in Technique 76.3. Step-by-step technique. Patient preparation. Local anesthesia is injected into the palmar skin just proximal to the metacarpophalangeal crease of the affected digit. The hand is positioned with the palm up, supported by a towel to allow hyperextension of the metacarpophalangeal crease. Needle insertion. A fine needle, typically 18 or 19 gauge, is introduced into the skin. The bevel of the needle must be oriented longitudinally along the flexor tendons, targeting the A1 pulley. Release maneuver. The needle is moved proximally and distally along the pulley, pressing down firmly. The surgeon feels for a grating or scraping sensation, which indicates the pulley fibers being cut. Confirmation of release. The patient is asked to actively flex and extend the digit. If triggering disappears and tendon motion is smooth, the release is complete. If needed, additional passes with the needle may be performed. Figures explanation. Figure 76.7 shows the surgical anatomy of open release with scissors separating the flexor sheath. Figure 76.8 illustrates the percutaneous technique. The needle is introduced just distal to the flexor crease, advanced along the pulley, and the release is complete when the grating sensation disappears and smooth motion is restored. Postoperative care. A compression dressing is applied and removed after 48 hours. Sutures, if placed, are removed between 10 and 14 days. Patients are encouraged to use the digit immediately, avoiding only forceful grip until full recovery. Key exam points. Bowler's thumb, remember it is a neuropathy due to repetitive trauma with perineural fibrosis affecting the digital nerves of the thumb. Trigger finger percutaneous release, main landmark is the A1 pulley with the needle oriented longitudinally. Success is confirmed when the grating sensation disappears and smooth motion is restored. Postoperative principle is early mobilization is always encouraged to prevent stiffness and recurrence.